Hi, this is Lori Lenicky, and I'm going to discuss principles and management of the spine and continue our discussion on the spine. So, when you're evaluating a patient, you will find their history, their systems review, and testing that you do an integral part of being able to diagnose what is going on with the spine. When we take a history, one of the main things we need to look for are red flags. This would be things such as pain at night that doesn't go away, any symptoms that don't seem to be from a musculoskeletal origin, signs of spinal cord compression, or any major pain that has not been fully assessed, either through a X-ray or through a physician taking a look at them. Many with low back pain also have some psychological distress. There are some questionnaires that you can give out. One is the Patient Health Questionnaire for Depression and Anxiety. It's the PHQ 4, or the Graded Chronic Pain Scale. These will also help you to better understand the psychological distress they're under, and you may need to make an appropriate referral. Also, pain patterns. When a patient is put into a specific bias class, there are definite pain patterns that we look at, and asking the appropriate questions on the history will help guide you through your objective examination. Now, with any injury or any pain, you're going to have patients who are in various stages of recovery, whether they're acute, subacute, or chronic. And how you treat each of these stages will be different in the spine and different based on each bias as compared to what you would do for somebody with chronic pain with a specific bias. Many people consider the acute stage 0 to 2 or 0 to 4 weeks. Delito, who is one of the main researchers who has done a lot on treatment-based classification, classifies patients being in the acute stage if they can't stand longer than 15 minutes, sit longer than 30 minutes, or walk more than a quarter of a mile without their symptoms worsening. So he uses more of a symptom-based approach to whether they're acute or chronic, and where most people use time. In the subacute phase, most people can do their basic ADLs, but there are still things that will provoke symptoms such as lifting, vacuuming, gardening. And in the chronic stage, the patient has a high demand of activities, but can have increased pain with this. All right, so let's talk about the protection phase. So this is the acute phase for most patients. What should we do to help these patients? So first, you need to educate the patient. Engage in all patient activities that help them perform safe self-management. So how can they do their basic daily tasks with the pain they have without an increase in pain? One of the things patients need to realize, and I've heard patients say this often, when you have back pain, you don't always look like you're hurt. If someone breaks their arm, they're in a cast and everyone helps them out. But when you hurt your back, you don't have that outward sign of being in pain. So educating the patient too that it is okay to ask for help. It is okay to decrease your activities, even though you may not look hurt. Next is decrease acute symptoms. So many of the things you've already learned how to do, modalities, massage, traction, these can be used to decrease these acute symptoms. Bed rest should not be utilized unless there is a fracture or a major significant back problem. I do tell patients to do relative rest. I don't want them out lifting heavy objects. I don't want them sitting in poor postures. I need them to be able to be mobile and moving around and not have complete bed rest. We also need to teach awareness of their cervical and pelvic positions. This is kind of posture re-education. Also learning that they can move their spine. So maybe teaching those pelvic tilts, teaching how to find a neutral spine, teaching neck, cervical, and scapular retraction exercises. Have them demonstrate safe postures. Show them how they can sit in a car properly, how they can sit at their desk properly, how they should be standing that doesn't increase stress on their back. The next is to initiate neuromuscular activation and control of core stabilizing muscles. We've already done some of this. We've done some where we work on the drawing in of your spine, working on multifidus contraction, gentle head nods, gentle cervical retraction. So these activities that get those muscles that we eventually want to work well, at least get them working. And the last thing is teach safe performance of activities of daily living. So teach them how to roll, sit, and stand with safe postures. Try to get them to progress their sitting and standing tolerance as much as they can, and encourage walking. Right now, we're going to talk about the protection phase and the specifics related to different biases when they are in the protection phase. So those who have an extension bias, they may, if it's very acute, they may present with that flexed posture because the nucleus of the disc has shifted posteriorly. They may not be able to stand up correctly. These people also may be shifted somewhat to the left or to the right. A lateral shift correction needs to occur to help these patients start their recovery process. And gentle extension exercises, especially exercises that are going to centralize their pain, in other words, move the pain that may go all the way down their leg to now the pain only goes down to their knee. That is significant progress in someone who has an extension bias. Diagnosis of these can be a disc lesion, it could be impaired flexed posture, it could be the fluid stasis within that nucleus that is causing these problems. For those who have a flexion bias, these are the ones who are much more comfortable when they're flexed. And extension tests generally make their pain worse or send the pain further down their leg or peripheralize their pain. And people who get this typically have spondylosis, lumbar stenosis, cervical stenosis, or maybe even extension load injuries. If you're lifting a heavy load overhead and you have your back into some lordosis and that load comes down on you, you could really hurt that posterior anatomy of the spine. Also, if your facet joints are irritated and swollen, when you close those facet joints like you would in extension, you may be irritating them. So the individual may stay flexed and forward to help control the pain. Those with a non-weight bearing bias, these patients like a traction approach. They have a hard time tolerating being upright for the activities of daily living. Any movement test make them worse, whether you're trying to flex them or trying to extend them, both, or even side bend or side glide. All movements seem to make the symptoms worse. So protection phase would be non-weight bearing procedures that relieve symptoms, or traction, or maybe even aquatic therapy to get the buoyancy of the water helping with taking weight off the spine. Right, individuals who have hypomobility need mobilization. They may need the mobilization manipulation to remove the restriction in one or more of those spinal segments. For the people who have soft tissue lesions, you need to treat them as if they're a muscle sprain. Muscle sprains, muscle tears, contusion, overuse, these are all part of this soft tissue lesion. And you would treat them just as if they had a muscle injury in the extremities. And postural pain syndrome. Now, these people present with faulty postures, and the pain is worse when they're in those faulty postures. First day early protection phases teach them to get out of those improper postures, perform postural correction, and then begin to strengthen the weakened and stretched out muscles and stretch out those tight muscles, and do some neuromuscular re-education to help them understand how to find spinal neutral and not put themselves in those end range positions that can cause pain. When we talked a little bit about this or in class of how important it is to get muscle activation, regardless of where the back pain is coming from. Spinal stabilization is a good thing. So whether they have a cervical or lumbar problem, you should begin to teach them how to activate those deep segmental muscles within the cervical and lumbar spine to help begin stabilizing their back. Another problem I see often is in the clinic is that therapists teach patients spinal stabilization exercises. Supine, they may move to quadruped, they may even move to standing. They never explain to the patient that spinal stabilization is something that's needed all the time. So if they're reaching into a cabinet to get a glass, if they don't stabilize their spine, they're going to perform a lot of arching when they reach up. If they are going up and down stairs, with every step, your back will be moving. But if you can learn to stabilize it, you'll have less movement. So make sure that you include functional movements in with your stabilization exercises so that the patient understands that stabilization is a process and not an exercise. All right, now we're moving into that next phase, the controlled motion phase, and this would be considered subacute for most patients. And so at this point, you want to educate the patient in self-management of pain and how to decrease these episodes of pain. You've already been able to demonstrate to the patient what they can do to decrease their pain and what they can do to control their pain. And so now you're hoping that they are able to do that on their own. Now you also want to make them aware of unwanted movement. So they need to be able to understand when stabilization is needed. If an area is tight, whether this is a muscle, a joint, a fascia, a nerve, this is a good time to start stretching that out. We'll get into nerve glides in MSK next year, but you should be comfortable stretching muscles, joint, and fascia at this point. You can also ensure that the patient has good neuromuscular control so that they can start to gain strength and endurance of the muscles we need. And also, cardiopulmonary endurance is very important. Many studies show that those who are more cardiovascularly trained have less back pain. And also teach relaxation and postural exercises. So making sure that a patient can relax and has the ability to relieve stress is key at this point. Right, as we're still discussing this controlled motion phase or the subacute phase, realize that pain may not be their major limiting impairment, but they will still have some pain with daily activities. At this point, you need to take a good look at whether they have the ability to perform good neuromuscular control and stabilization, check their postural awareness, check their body mechanics, look at their flexibility and strength. There may be tight musculature that you can stretch out now that you wouldn't have been able to stretch out during the acute phase. And also a good conditioning program to make sure they're cardiovascularly intact is a good idea. And some of the way we treat is going to shift at this point. So for pain modulation, you want to try to decrease your use of modalities and passive activities with the patient for pain control. At this point, the patient should be increasing their postural awareness, increasing strength and mobility, and gaining spinal control to be able to handle their pain. And kinesthetic training goes along with spinal stabilization exercises. So getting your body to understand what it takes to control the spine in a feed-forward motor control concept is very important. And when you find those tight muscles or tight joints, stretching, mobilization, and manipulation is safe to do at this point for most patients. Working on their muscular strength is also very important at this stage. This is appropriate once their pain is under control and there's no inflammation. And again, we mentioned cardiopulmonary training to make sure that they are able to safely return to an aerobic conditioning program. All right, still continuing on the controlled motion phase, more treatments that you can do is postural stress management and relaxation exercises. So think of a patient who is on the phone all day and they hold their phone between their shoulder and their ear. They're sitting, studying all evening and sitting in a laptop on a couch with bad posture. even those who drive a truck. Most people who drive a truck don't sit with perfect posture. They're sitting with a decreased lumbar lordosis and increased thoracic kyphosis. And they may need training at this point to correct those postures. Also work on functional activities. So what they need to do in their daily life, make sure that you're incorporating that into their treatment so that they can get back to the lifestyle they want to get back to. All right, and finally, we're going to talk about the return to function phase. This is when their pain is under control. They may have slight pain with certain activities, but overall, there's only pain with excessive stress. Many people in this phase still have poor neuromuscular control and poor endurance for high intensity exercises. There may still be strength or flexibility imbalances and generally deconditioned. So, what can you do with these patients? First, emphasize spinal control, especially with high intensity and repetitive activities. Those are the activities that are going to wear the spine down the most. And so, if the patient can be taught to control the location of their spine and increase stability, they'll be able to return to their normal tasks faster. Also, you need to increase mobility of the restricted joints, muscle, and fascia. So, just as we started in the controlled motion phase, we're going to continue that here. Also progress dynamic trunk and extremity resistance exercises and making sure that it's functional. You want to increase cardiopulmonary endurance through aerobic exercises. Emphasize the habitual use of techniques for stress relief, relaxation, and postural correction. Teach safe progression to higher activities. So making sure that they can do the basic activities safely and then start to progress to the activities they want to do. And also teach healthy exercise habits. Make sure that before the patient leaves you that they understand how important continuing to exercise is and how that will decrease their chance of having future back pain. And finally, you may have noticed that we didn't include the non-weight bearing bias in the exercises above. That is because many of the exercises initially are not going to help. They do need traction or some kind of unweighting exercise, such as the pull. Once their symptoms are under control, the progression is based on impairment. So if their pain is very minimal and you can continue to do traction or aquatic-based exercises, but you also need to start working on mobility of anything that is tight or stability of anything that is weak and loose. If repeated movements help the patient, you may feel that they have either a flexion or extension bias. And so these patients can fit into the other categories once you get the symptoms under control from their non-weight bearing bias. That concludes this podcast. I will do another podcast on more information from the spine chapters. Thank you.